Welcome to the deep dive. Today, we are tackling something that's, well, really at the heart of pediatric nursing, the health assessment. It's definitely not just running down a checklist.
No, not at all. It's more like uh, trying to get this incredibly detailed snapshot of a child's health, their growth, their development.
Exactly, and doing it while they might be scared, anxious, or just plain uncooperative. It's a real balancing act.
That's the perfect way to put it. So our mission today is really to get a handle on the strategies from Chapter 10, Health Assessment of Children.
Yeah.
We want to go beyond just the facts.
Right.
It's about developing that clinical judgment,
Yeah.
because your skill in adapting, observing, and just plain getting the child on board.
Yeah.
That's everything. Bad data is worse than no data sometimes.
So true. So for you listening, maybe getting ready for clinicals, we're zeroing in on that core challenge. How do you get the detailed info you need without traumatizing the child?
Yeah.
We'll look at the art of the health history, building that instant trust, how you talk differently to a 2-year-old versus a 14-year-old.
And then the physical exam itself, that systematic approach, but also that crucial golden rule about the sequence, what to do when. Plus, interpreting things like vital signs, growth charts, and the Tanner stages.
Okay, let's dive in. Where do we start?
Well, the absolute foundation is the health history. This is where those fundamental human skills really come into play. Building rapport, showing respect, really listening. Empathy is huge.
And observation, you mentioned that, not just listening, but watching.
Yes, systematic observation is like being a detective, because sometimes the most important developmental clues, they pop up when the child is just relaxed, playing, not even aware you're assessing.
Ah, that's a great clinical insight, like seeing how they walk when they just run down the hall on their own.
Exactly. That's your gait assessment right there.
Right.
Or if they're balancing to grab a toy, you're checking cerebellar function without even announcing it. You weave the assessment into the interaction. Kids just won't cooperate like adults on an exam table.
Makes sense. So setting the stage for that history is important too, right? The environment.
Absolutely. You need privacy, good lighting. And here's a practical tip. Sit down. Sit down when you talk to the child and caregiver.
Oh, interesting. Why?
Standing over them can feel intimidating, like an interrogation. Sitting down just feels more relaxed, more welcoming. It helps level the power dynamic a bit.
Okay, good point. And when talking to the parent or a caregiver,
Use open-ended questions. Definitely. Don't just ask yes-no stuff. And have some toys or books handy to keep the child busy while you talk.
good idea.
And use that time. Watch how the parent and child interact. How do they respond to the baby's cries or the toddler's meltdown? Those little moments tell you so much about their dynamic. It's invaluable data.
Before we go further, there's a couple of important safety points we need to mention here.
Yes, good call.
First, for the nurse's own safety, the take note about positioning yourself near the door. If you ever feel uncomfortable with a family member, don't hesitate. Alert security.
Crucial. Always trust your gut.
And second, that Joint Commission National Patient Safety Goal, Goal 3. Accurate medication reconciliation. The history is where you nail this down. Confirm every single medication dose frequency. It's vital for safe care transitions.
Absolutely critical. Okay, so now, approaching the child themselves, how do we do that effectively?
You want to be professional, but warm.
Hmm?
You're not trying to be their best friend, but you need to be approachable. Maybe use a colorful stethoscope. Let them see it's not scary.
Uh-huh. Make eye contact. Use slow, predictable gestures. Nothing sudden. And for those really shy kids,
Sometimes you let them kind of be invisible for a bit, let them warm up on their own terms. Gentle, non-threatening touch, like a hand on the arm, can work wonders, especially for newborns, but you have to read their cues. Don't force it.
right? And then comes the tailoring, adjusting your communication based on their age. This is where the real art comes in.
Definitely. Let's break it down. Toddlers and preschoolers, what's the key?
Control. Give them control over things that don't really matter clinically. Let them pick the order sometimes. Should I listen to your tummy or look in your ear first?
Okay.
Ask them to point where it hurts. But remember, their understanding of inside their body is limited, so you always need the parent to help clarify or confirm that.
Makes sense. Then school-aged kids, say 6 to 12.
Now they're much better historians. They can usually tell you about school, friends, what they like to do. So start with them. Ask them the questions first.
Ah, direct it to the child.
Yes. Then you can bring the parent in to fill in gaps or provide more detail, but give the child the first chance to tell their story.
Okay. And then adolescence. The ultimate challenge sometimes.
Huh. It can feel like a tightrope walk, can't it? Trust is absolutely everything here. First step, Ask them if they want their parent in the room for the history. Give them that choice.
And confidentiality is paramount.
It's the key that unlocks everything. You have to start with neutral stuff, school, hobbies, maybe work. Build that rapport before you get into the sensitive topics like substance use, sexuality, mental health concerns like depression or suicidal thoughts.
But crucially, you have to explain the limits of confidentiality up front, right?
Absolutely. You must tell them that if they reveal something that puts them or someone else in serious danger, you are legally and ethically obligated to report that. You need to be crystal clear about those boundaries.
And maintain your role. Don't try to be their friend or peer. You're the healthcare professional. That boundary is important for trust, too, paradoxically.
Exactly right. Okay, so let's move into the specific components of that comprehensive history. What are we actually collecting?
Well, beyond the basics like name and age, the demographics need to include who's giving the history of the historian and are they reliable, and what's the household setup like.
Right, then the chief complaint, CC. This needs to be recorded exactly in the parent's or child's own words, verbatim.
Yeah, put it in quotes. And the history of present illness, HPI, is where you get the whole story of that complaint. Onset, duration, what makes it better or worse, any exposures, treatments they've already tried, all details.
Then the past health history. This is really broad in PEDS. You need the prenatal and birth history, any chronic conditions, major accidents or injuries, a detailed diet history.
Allergies, too, and not just what they're allergic to, but the specific reaction and how severe it was. That's critical.
So critical. And immunizations, of course. And for older girls, pre-adolescents, and adolescents, you need a menstrual history.
We also need a good family health history, usually going back 3 generations.
And this is often where using a genogram comes in handy.
Yeah.
You know, that visual family tree, figure 10.1 in the text shows it.
Right. The genogram helps you quickly spot patterns like inherited conditions, maybe early heart disease running in the family, certain cancers. It guides your future screening and advice.
Exactly. Then the review of systems, ROS. This covers everything head to toe, like Table 10.1 shows. But instead of just listing systems, think about the pediatric-specific questions.
Good point. Like what?
Well, for eyes vision, you might ask, does she sit really close to the TV? Or does he squint or complain about reading? For GI, maybe, does he ever hold his poop? Or any pain when going to the bathroom? These are the targeted questions.
Got it. And then there's the functional history and home environment.
Right. Functional history is about daily life. Safety stuff, car seats used correctly, helmets for biking, nutrition, often a 24-hour recall, how much physical activity, sleep patterns, elimination, and importantly, relationships, coping styles, how discipline is handled at home.
And the home environment assessment looks at who lives there, employment, financial stability, do they need resources like SNTAM or WIC, any major family changes. And the physical home itself, is it safe? Utilities okay? Any pets or issues like infestations?
And that critical take note about lead paint risk. Always ask about the age of the house, especially if built before 1978. Lead exposure is a serious preventable risk.
Okay, so that's a really thorough history. Now let's shift gears to the hands-on part, the physical examination.
Right, and the absolute foundation here is you have to tailor everything to the child, their age, their mood that day, how sick they are. It all dictates your approach. Preparation is key. Get your equipment ready. Have a calm, matter-of-fact attitude.
This brings us to what you call the golden rule of the pediatric physical exam. Can you explain that again?
Simple but crucial. The sequence of the exam is driven entirely by the need to maintain cooperation and minimize trauma.
So not always head to toe like with adults.
Not necessarily. For an older cooperative child or teen, sure, head to toe works fine. But for infants and toddlers, absolutely not. You save the most invasive, most upsetting parts for the very, very end.
Like looking in the ears, nose, mouth, throat.
Exactly. Especially the throat check. That's often the point where cooperation ends abruptly, so get everything else done first.
Okay, so for an infant, if they're quiet or even asleep when you start,
jump right into auscultation. Listen to the heart, the lungs, the abdomen while they're calm. Keep them on the parent's lap or shoulder. That security is huge. And hold off on things like the Moro reflex, the startle reflex, until the very end.
And for toddlers and preschoolers, what are the tricks?
Play is your best friend. Let them touch the stethoscope. Maybe listen to their teddy bear first. Incorporate games. Let them put their shirt back on after you listen to their chest before moving to the belly.
Give them back that control piece by piece.
Right. Use short, direct phrases like, I'm going to look in your ear now, instead of asking permission, which just invites a no. For preschoolers, you can make deep breathing a game. Can you blow out the light on my pen light?
Clever. Okay, so the exam always starts with general appearance, right? your first look.
Never underestimate that first impression. Do they look well, playful? Or are they listless, pale, acutely ill? Also note their posture. Newborns are typically flexed. Toddlers often have that sway back, the lordosis, maybe bow legs, pot belly. School age and adolescents should be more upright. Are they appropriate for their age? Alert. Engaged.
Then, vital signs. Key point here.
Measure them when the child is quietest. Activity, crying at all skews the numbers, especially heart rate and respirations. And remember, what's normal changes drastically with age.
Let's talk temperature.
Use the least invasive method appropriate. Tympanic is usually okay for kids over 3 months. Temporal artery is common, but maybe less reliable in really sick infants under 90 days. Clinical judgment needed there. Rectal. Generally avoided if the child is immunosuppressed, has diarrhea, or any bleeding issues. Oral temps are usually fine by age 5 or so. Okay. Pulse and respirations.
Big age variations, like you said. Table 10.3 shows this clearly. Infant heart rate can be 8150, respirations 2055. Both slow down as they grow. For kids under 10, listen to the apical pulse for a full minute. The radiant pulse is just too hard to feel reliably in little ones, especially under 2.
And remember that infant breathing pattern is often naturally irregular. Don't panic at slight pauses.
Good point. Blood pressure, when do we start routinely checking that?
Usually after age 3, unless there are specific risk factors like heart problems or kidney disease. And cuff size is everything. Too small gives a false high, too big gives a false low. The bladder width should be about 40% of the arm circumference, and the length 80–100%.
And if you get a high reading with an automated cuff?
You must repeat it manually using auscultation. That's still the gold standard for confirming hypertension.
Okay. And the fifth vital sign? Pain assessment.
Crucial. For kids who can't talk or have language barriers, use the FLACC scale, looking at their face, legs, activity, cry, and consolability. For older kids, the Wong-Baker Faces scale or a numeric scale works, but make sure they understand. Explain that the highest number or the crying face means the worst pain you can imagine, but they don't have to be crying to feel that level of pain.
Right, separating the feeling from the expression. Good point. Okay, let's move to body measurements. These seem really fundamental in peds.
They absolutely are. Critical for tracking growth and nutrition. We measure length using a recumbent measuring board for infants and toddlers under 24 months or until they can stand steadily. Then we switch to height using a wall-mounted stadiometer.
And the most important step.
Plotting. Every single measurement needs to be plotted on the correct WHO or CDC growth chart for their age and sex.
And it's the trend over time that matters most, not just one dot on the chart.
Exactly. That's especially true for BMI, which we calculate from age 2 up to 20. It helps screen for underweight, risk for overweight, and overweight status using percentiles. A single high reading is a flag, but the pattern tells the real story. It's a Healthy People 2030 objective, tackling obesity.
We also measure head circumference routinely until age 3, right, at the largest point.
Correct. Now onto skin, hair, and nails. Lots of normal variations here.
Like acrocyanosis.
Right, that bluish tint to the hands and feet in newborns. Totally normal for the first few days. Mottling, that lacy pattern, can just be a response to cold. Lanugo, the fine downy hair, is common in preterm infants in some ethnicities.
But the big red flag for skin color?
Central cyanosis, blueness around the lips, on the tongue, or on the trunk. That signals hypoxia and needs immediate attention.
What about birthmarks or lesions?
Well, you see hyperpigmented nevi, often called Mongolian spots, frequently in infants with darker skin. They look like bruises, but they're not. They fade over time. It's vital not to mistake them for abuse. Then there are vascular lesions like salmon patches, stork bites, or nevus flammeus, port wine stains, which might need monitoring if associated with other syndromes.
And assessing hydration through the skin.
Checking skin turgor. Gently pinch up a fold of skin, usually on the abdomen or maybe the back of the hand. If it stays pinched up or tented, that's a strong sign of moderate to severe dehydration.
Okay. Moving up to the head and neck, fontanels are key here.
Yet the soft spots, figure 10.1cn shows them. The anterior one on top usually closes between 9 and 18 months. The smaller posterior one closes much earlier, by about 2 months.
And what are we assessing besides closure time?
The tension. They should feel soft and flat. A bulging fontanelle could mean increased pressure inside the head, maybe hydrocephalus, or even just overhydration. A sunken fontanelle screams dehydration. Also, unusually large fontanelles might hint at things like Down syndrome or hypothyroidism.
Good to know. What about the neck?
Check for full range of motion. Unless there's any suspicion of trauma, then you don't move the neck. You might feel small, movable, non-tender lymph nodes in the neck, cervical nodes, in healthy kids between 1 and 11 years. That's often normal.
All right, let's tackle eyes and vision. Per LA is standard.
Pupils equal, round, reactive to light and accommodation. Check. Developmentally, remember that intermittent strabismus or eye crossing can be normal up until about 3 months.
But if it persists,
Persistent crossing after 6 months needs a referral to ophthalmology. Always check for that. Use the Hirschberg test, corneal light reflex, to check alignment, and the absolute critical red flag for eyes.
absence of the red reflex.
Exactly. If you don't see that reddish-orange glow reflecting back when you shine your ophthalmoscope light, report it immediately. It could be in cataracts, retinoblastoma, other serious issues.
Okay, ears and nose. Anything unique to kids?
Well, young infants, say up to 3 to 6 months, are often considered obligate nose breathers, so nasal congestion can be a big deal for them.
And for looking inside the ear with an otoscope.
Technique changes with age. For kids under 3 years, pull the outer ear down and back to straighten the canal. For kids over 3, pull it up and back, just like adults. You're looking for that pearly, pinkish-gray, translucent tympanic membrane.
And a safety warning about foreign objects in the ear or nose?
Yes, super important. If you suspect something stuck in there, don't try to flush it with water until you know what it is. If it's something like a bean, a pea, any kind of vegetable matter, water will make it swell up and could cause a complete blockage. Needs careful removal.
Good tip. Moving down to the thorax and lungs.
Check the shape first. Any deformities like pectus excavatum, sunken chest, or carinatum, pigeon chest. Note how the chest shape changes from round in newborns to the more oval adult shape by age 5 or 6.
And signs of breathing trouble.
Look for retractions, pulling in of the skin between the ribs, intercostal, below the ribs, subcostal, or above the sternum, suprasternal. That means they're working hard to breathe.
What about listening to the lungs?
Remember, kids have thin chest walls, so breath sounds are naturally louder and easier to hear than in adults. Sometimes upper airway sounds get transmitted down, so you need to carefully distinguish normal loud sounds from true adventitious sounds like wheezes or crackles.
Okay. And the heart exam?
Location of the PMI, the point of maximal impulse, shifts down and slightly out as the child grows. Figure 10.29 shows this. Also, don't be surprised by sinus arrhythmia.
Where the heart rate speeds up a bit when they breathe in and slows when they breathe out.
Exactly. Totally normal and benign finding in kids. If you hear a murmur, you need to describe it. Timing, systolic, diastolic, location, loudness using the grading scale. Table 10.5.
And innocent murmurs are common.
Very common. Usually systolic, often sound kind of musical or vibratory, and they typically get quieter or disappear when the child changes position, like sitting up or standing.
Okay, now for something that requires sensitivity, assessing sexual maturity using the Tanner stages.
Yes, this is a standard part of the adolescent exam. It's crucial for assessing normal development. There are 5 stages describing the changes in female breast development and pubic hair, figure 10.28, 10.34, and male genital development and pubic hair, figure 10.36.
It gives context to their growth spurt and overall health.
Precisely. And a note, if you see some breast enlargement in an adolescent boy called gynecomastia, remember it's usually temporary, caused by hormone shifts during puberty, and typically resolves on its own. Still needs documentation, though.
Good to know. Last couple of systems, musculoskeletal and neurologic.
For musculoskeletal, observes posture again. Toddlers often have that wide-based gait and lordosis we mentioned. Adolescents during their rapid growth spurt might show some temporary kyphosis or rounding of the upper back.
And we screen for scoliosis.
Yes, screen pre-adolescents and adolescents for scoliosis curvature of the spine by having them bend forward at the waist and looking for asymmetry in the back or ribs.
And neurologic. Reflexes are big here, right?
Huge. You assess primitive reflexes in infants, like the palmar grasp, sucking moro. These should disappear by specific ages as the nervous system matures. For example, the palmar grasp is usually gone by 3-4 months.
And if they don't disappear on schedule?
That's a red flag. Persistence of primitive reflexes past the expected age strongly suggests a potential neurologic issue. As primitive reflexes fade, protective reflexes like writing and parachute reflexes emerge.
What about deep tendon reflexes?
They tend to be brisk, maybe 3+ cento in newborns, then settle down to the average 2+ by around 4 months old. You also test balance and coordination cerebellar function using tests like the Romberg test, stand with eyes closed, or having them do things like run heel to shin smoothly. Box 10.3 lists several tests.
Wow, that covers a lot of ground. We went through the history, the exam sequence, vitals, growth, all the key systems. It really highlights how detailed and adaptable pediatric assessment needs to be.
It really does. The core message is that it's this dynamic process. You're constantly integrating what the parent tells you, what you know about normal development for that age, and what you're actually seeing and hearing right in front of you.
And constantly adjusting that exam sequence to keep the child as comfortable and cooperative as possible.
Absolutely. Which brings me to a final thought, maybe something for you to consider as you integrate all this. We talked a lot about techniques, distraction, play, sequence.
Uh-huh.
But what really strikes me, looking at Chapter 10 as a whole, is how much it all boils down to the concept of control. Or, more often, the child's lack of control in a healthcare setting.
Interesting point.
Think about it. Letting the toddler choose the order, giving the preschooler a job, ensuring confidentiality for the teen. It's all about giving back small measures of control in a situation where they often feel powerless. Recognizing and addressing that fundamental need for control, I think, is maybe the most powerful principle underpinning successful pediatric interaction, from infancy right through adolescence.
That's a really insightful takeaway, giving back control wherever possible. I like that. So for everyone listening, definitely go back and review those specific vital sign ranges for different ages, the developmental milestones, and especially those critical red flags we highlighted throughout.
Yes, absolutely. Well, that wraps up our deep dive for today. Thanks for joining us and letting us guide you through these key concepts.